Hello everyone, this is Dr. Arun from Techniq College. Here we are going to discuss about suture material and suturing techniques. Overview of this presentation, definition, goals of suturing, suturing characteristic, armamentarium of suturing, suturing material, principle of suturing technique, surgical knot, removal of a suture, reasons of failure of a suture, possible complication, alternatives to the suture. Definition: what is a suture? Suture is a stitch or a series of sutures made to secure the opposite edge of a surgical or traumatic wound close together. What is a suture material? Suture material is an artificial fiber used to keep the wound together until they hold themselves by a natural, which is a synthetic woven into a stronger scar. Goals of suturing: wound edge apposition, provide adequate tension, maintain hemostasis, aid in wound healing, avoid wound infection, produce aesthetically pleasing scar by approximation of skin edges. Suturing characteristics. Physical suture, monofilament. This suture material is smooth and tends to slide through the tissues easily. Difficult to knot, can damage by gripping it with a needle holder or forceps. This can lead to the fracture of suture materials. Suture characteristic of a multifilament suture are easy to knot, have a greater surface area other than the monofilament, have a capillary action where the bacteria may lodge and responsible for the persistent infection. The material can be coated with a silicone to make it smooth. Difference between monofilament and multifilament suture. Suture characteristic: tensile strength. It can be expressed as a force required to break it when the pulling the two ends apart. It depends upon the constitution of the suture material, thickness of the suture material, how it is handled in the tissues. Observability: suture material may be observable or non-observable. This is a property may be taken into consideration when choosing a suture material for specific wound closure. The oral mucosa and deeper structure needed to observable suture material, but the vascular anastomosis needed a non-observable suture material. Biological behavior: it depends upon the constitution of a raw material. Armamentarium for suturing: needle holder, suture needle, and a suture material. Parts of a needle holder are working tip or jaw, hinge joint, shank or body, catch mechanism or ratchet, and grip area. How to hold a needle holder? The needle holder is held with the thumb and the ring finger through the ring with the index finger along the length of a needle holder to provide a stability and control. A suture needle. It is made up of either a stainless steel or carbon steel. Parts are tip or point, body or shaft, eye or swagged end. Shape of a needle: 1 by 4, 3 by 8, 1 by 2, 5 by 8 circle, J shape, common curve, and straight. Classification of a suture needle. According to shape, straight or curved. According to eye, eyed needle or traumatic, eyeless needle or atraumatic. According to cutting end, round body or cutting body. Cutting body is further divided into conventional or reverse cutting. According to its tip, triangular, round, or blunt. Suture material. Ideal properties of suture material are easy to handle, predictable behaviors in tissue, predictable tensile strength, sterile, secure knotting ability, minimal tissue reaction, non-allergic, non-carcinogenic, and non-shrinkage. Classification of suture material. According to the source, natural, synthetic, and metallic. According to the structure, monofilament, multifilament. According to fate, observable and non-observable. According to coating, coated or uncoated. Natural observable suture are catgut, foam catgut, collagen, fascia lata, and beef tendon. Non-observable natural suture material are silk, silkworm gut, linen, cotton, and rame. Synthetic observable suture material are polyglycolic acid, polylactic acid, polyglactin, polydioxone. Non-observable synthetic suture material are nylon, polypropylene, polyester, and polyethylene. Metallic are stainless steel, tantalum, silver, gold, and aluminium. Non-observable monofilament suture are polypropylene, polyester, nylon, and polyvinyl evidine fluoride (PVDF) suture, and observable monofilament suture are catgut, foam catgut, vicryl, and BDS. Multifilament observable suture are Y-grade polyglycolic acid. Non-observable multifilament suture are silk, cotton, linen. Difference between monofilament and multifilament. Monofilament suture has a no capillary action, less infection risk, smooth tissue passage, high tensile strength, and more throws are required. Multifilament has a capillary action, increase in the infection risk, less smooth passage, less tensile strength, better knot security. Observable versus non-observable suture material. Observable suture material are degraded by enzyme, hydrolysis, or phagocytosis, used to hold the edges in approximator temporarily until the wound heals. Non-observable suture material, encapsulated or walled off by fibrosis, used to suture site at where the tensile need to be maintained. Overview. Suture can be divided into observable and non-observable suture material. Observable is further divided into synthetic and natural. In synthetic, there are three suture material: monocryl, vicryl, and PDS. Natural collagens. Non-observable suture material is also further divided into synthetic and natural. Synthetic, it is synthetic suture material or ethylene and prolene. Natural suture material are surgical cotton, surgical steel, and surgical silk. Criteria for selection of a suture material. Condition of a wound, tissue to be repaired, tensile strength, not holding characteristic, reaction of a surrounding tissues. Commonly used suture material, polypropylene. It is a synthetic non-absorbable monofilament suture material. Polymer as a propylene. Uses. It is used in general surgery, plastic surgery, cardiovascular surgery, and skin closure. Advantages: won't use tensile strength over a time, good knot security, very little tissue reaction, high plasticity. Disadvantages are stretch when pulled, loosen when edema subsides. Silk, it is a non-absorbable multifilament suture material made from a filament spoon from a silkworm larvae. Uses in ophthalmic surgery, general surgery, and plastic surgery. Advantage of a silk suturing are ease of handling, good knot security, cost effective. Disadvantages are very reactive, can't use in the presence of infection. Vicryl. Vicryl, it is a synthetic absorbable suture material, monofilament or multifilament, uncoated or uncoated. Available in purple colored or undyed. Uses intraoral suturing, gut anastomosis, vascular ligature, ophthalmic surgery, superficial knot tissue approximation of skin and soft tissues. Advantage of vicryl suturing are minimal tissue reactivity, can be used in infected tissue, stronger than gut, retains strength more than 3 weeks. Disadvantages are in case of prolonged approximation can be used, delayed absorption and increase in the inflammation. Used to different sizes of suture. Face 5O to 6O, scalp 3O to 5O, chest 3O to 4O, back 3O to 4O, abdomen 3O to 4O, extremities 4O to 5O, joint 3O to 4O, oral 3O to 5O, observable. Biological response to the suture material. The early response is generally acute aseptic inflammation involving the primarily polymorphic nuclear leukocytes. After a few days, mononuclear cells, fibroblasts, and histiocytes became evident. Capillary formation occurred at the end of a initial phase. Biological response to the suture material. Natural observable proteolytic degeneration and intense tissue response. Synthetic observable hydrolysis less intense response. Non-observable suture material are encapsulated acellular response. Principles of suturing. Principles of suturing. The needle should be grasped approximately at one-third of distance from the eye and two-thirds from the point. The needle should be pierced to the tissue perpendicular to its surface. The needle should be placed equidistant 2 to 3 mm from the incision line. Principles of suturing. The depth of penetration should be equal on both sides of the incision line. The needle always passes from movable tissue to the fixed tissue. The thinner the tissue to the thicker tissue, deeper tissue to the superficial tissue. The tissue never be closed under tension. Each suture must be placed 3 to 4 mm apart from the incision line. Suturing technique: interrupted suture, continuous suture, matrix suture, figure of 8 suture, and subcuticular suture. Interrupted suture. The uses of interrupted suture are closure after the wound, after single tooth extraction, third molar extraction, biopsy, and dental implant. Advantages of interrupted suture: simple, performed in an urgent situation, easy to remove. Disadvantages: failure to bring all surface in contact, less supportive for healing. Technique for interrupted suture: cleansing and debridement. Selection of appropriate suture. The wound margin are accurately opposed. The suture needle is held with a needle holder and positioned at one-third of a length from the suture, away from the end of a suture attachment. A bite of a skin is taken at a landmark height. The suture needle is advanced to the depth of a wound margin and then out through the wound opening. The needle is then inserted via the depth of a wound and rotated up through the opposite side of a margin, the landmark side for a portion of wound. Continuous suture. Continuous suture are three types: simple continuous suture, locking continuous suture, and continuous over and over. Simple continuous suture uses well approximated wound with minimal tension. Advantages: rapid tissue for closure, even distribution of tension over the suture line can be used in swell up tissues. Simple continuous suture disadvantages are should not be used in the areas of existing tension. Not possible to free the few sutures at the time. When one suture breaks, it affects the whole closure. For simple continuous suture, the beginning of a simple continuous suture is similar to the type of a simple interrupted suture. The needle is then reinserted in a continuous fashion such that the suture passes perpendicular to the incision line. The suture is ended by passing a square knot over a untied end of a suture. Technique for simple continuous suture. Diagrammatic representation. Logging continuous suture. It can be used in long adventitious area, tuberosities and electromolar areas. Advantages. Avoid multiple knot of interrupted suture. Logging continuous suture technique. At first, the single interrupted suture is used to make a tie. The needle is then inserted through the underlying surface of a flap. The needle is then passed through the remaining loop of a suture and the suture material is pulled tightly, thus the logging it. The procedure is continued until the final suture is tied off at the terminal end. Continuous over and over suture. Initially, a simple interrupted suture is placed and the needle is then reinserted into a continuous fashion such that the suture passes perpendicular to the incision line below the oblique hole. The suture is ended by passing a knot over an untighted end of a suture. It provides a rapid technique for closure and distribute the tension uniformly over a suture line. It also offers a more watertight closure. Diagrammatic representation of over layered closure. Wounds that involve only the skin are often best closed with a single layer of interrupted suture. In case of a deep wound, the tissue should be closed in the layers to remove the dead space and confers the strength to the wound. The technique for layer closures involves the closing the deeper tissue first, usually the continuous suture, and then closing the skin with the interrupted suture. Diagrammatic representation of a layer closure. Deeper layer should be closer first, and the epidermal layer can be closer next. Matrix suture. This suture must be horizontal or vertical. Uses of horizontal matrix sutures are intraoral bone grafting, closure of the extraction socket. Advantages: provide a broad contact of the wound margin, provides a watertight closure. Disadvantages: if improperly used, bone necrosis and wound dehiscence may occur due to limited blood supply. Technique: the needle is passed from one edge of incision to another edge, again from the latter edge to the first edge in a horizontal manner. The knot is tied. The distance of a needle penetration from the incision line and the depth of penetration of a needle is the same for each and entry point. Horizontal distance of a point of the penetration on the same side of a flap differs. The needle penetration through the surgical flap should be at least 8 mm from the flap edge. This procedure is continued till the entire length of incision and the knot is tied. Vertical matrix suture. It is similar to the horizontal matrix suture except the depth of penetration. Therefore, when the needle is brought back from the second flap to the first flap, the depth of penetration is more superficial. Uses are closing the deep wound abdomen or a hip. Advantages: decrease the dead space and providing the increase in the strength. Didn't interfere with the healing. Disadvantages: approximation is difficult. Overview of vertical matrix suture. Pair of 8 suture. Most commonly used for extraction socket closure and well adapted on a gingiva papilla around the tooth. Technique: the needle is first inserted into the outer surface of a buccal flap and then the lingual flap. The suturing begins at the buccal surface 3 to 4 mm from the tip of papilla. Then the needle should be inserted in the same fashion at the horizontal distance and then both ended or tied up. Advantages: rapid closure. Disadvantages: due to the orientation, it is difficult to remove and it is leaves a significant amount of suture thread inside the socket. Subcuticular suture. Usually a running stitch, but they can be interrupted. Intradermal horizontal bites allow suture to remain for a longer period of time without the development of cross-hatching scar. Uses simple, uncomplicated wound. Subcuticular suture advantages are excellent cosmetic closure, no stitch to remove. Disadvantages: technically more difficult to master, doesn't hold in thin skin. Surgical knots. Suturing knot has a three component: loop, knot, and ears. The loop created by the knot. The knot itself is a component of a number of tight throws. Ears, which are the content of a suture. Principles of knot tying. Use the simplest knot that prevents the slippage. Tying the knot as small as possible on the cutting edge of a suture as short as reasonable to minimize the foreign body reaction. Avoid friction or sawing. Avoid excessive tension. Try suture too tightly to strangulate the tissue. Maintain the traction at the one end of a suture after the first loop is thrown. Placing the final throw as horizontally as possible to keep the knot flat, limiting the extra throws to knot as they do not add additional strength to property tight knot. Different types of a knot. Secure or square knot, surgeon's knot, granny's knot or slip knot. The first throw is placed in a precise position for a knot using a double loop. The second throw is tied using a horizontal tension. Additional two throws are desirable. Totally, there should be a four throws, best for catgut, silk and cotton and stainless steel. Surgeon's knot. Formed by two throws on a first tie, one throw on an opposite direction in a second tie. Recommended for tying a polyester suture material such as a vicryl and Polypropylene. A tie in a one direction and followed by a tie in the same direction and the third tie in the opposite direction to square the knot and hold it permanently. Can be used in silk, chrome gadget or plain gadget. Overview of a granny knot. Removal of a suture. All sutures are being a foreign bodies cause irritation to the tissue. Hence, we have a potential cause of a scarring. The skin sutures are removed as soon as the tissue healing allows. Non-absorbable sutures are best removed from the face after a period of 5 to 6 days. Tissues such as the scalp may require a longer period of days, 7 to 10 days. Removal of a suture. The suture in the face can be removed in 3 to 5 days. Lip can be removed in 3 to 5 days. Oral cavity can be removed in 6 to 8 days. The neck can be removed in 5 to 6 days. Scalp 7 to 10 days. Chest 10 to 14 days. Abdomen 10 to 14 days. Leg 10 to 14 days. Principle of suture removal. The suture area is first cleaned with a normal saline. The suture is grasped with a non-suture descending forceps and lifted above the epithelial surface. The scissors are then passed through the one loop and then transected close to the surface, avoid the dragging and contaminated suture material through the tissues. The suture is then pulled towards the incision line to prevent the dehiscence. If the suture is interrupted in a scab, application of hydrogen peroxide or normal saline is necessary. If the piece of a suture left, infection may occur. Reason for failure of suture: breakage, cuts out, knot slips, intruded suture, resolves too rapidly, remove too early. Possible complication of leaving a suture for many days: sutural abscess, scar or stitch mark, and dermoid cyst. Alternative to suture: stabils, tissue adhesives, tape. Disadvantages: not absolute alternative to mechanical means, more tissue reaction. Suture material. Thank you everyone.